as I was hosting the GI Health Summit. One of the people that she works with, Dr. Mandy Menino, was on recently talking about incontinence and pelvic floor therapy. And now Dr. Julie Sarton is coming on to talk about what happens when sex hurts. And guess what? It does often for people, especially ladies, as they get older. And she is going to tell you what to do about it. Please welcome to the show, Dr. Julie Sarton. Thank you for being here. And I love this topic. It's so one of those things, just like the GI health, that people are embarrassed to talk about. And we have to talk about these things so we can get people feeling better.
Absolutely. Thank you so much for having me on. I'm so excited because, as you know, this topic is, quote, taboo, and it does not get the attention it deserves. So I get so excited when I have a platform to be able to share more information about it. Today, we're going to hone in specifically on women. So men can have the same issue, but because women in general have been underserved more than men in this arena, we're focusing on all the ladies today. So if we ever want to talk about male pelvic pain or pelvic sexual dysfunction, we got to do a different show.
Absolutely. Well, you guys were so popular on the summit, and Mandy was so popular. Everybody was asking if she was married. So you guys are welcome to come back together or alone. And I believe somebody even went to you guys from seeing you on the show, if I'm not mistaken. I'm not 100% sure, but they'd asked for the phone number. So that's very cool, because people can see you guys in person if they live in the Orange, or if they're willing to travel to Orange County. And I think you even could do a lot of your things through telemedicine now.
We do. Yes. So we do a combination. At the end of the day, eventually we like to get patients in because we need to get our hands on patients, but there's a lot that we can do, hopefully, that people learn today that they can do. So we work to empower them and give them a bunch of tools to start treating themselves.
Terrific. Well, I can't wait to see your presentation. I'm going to mute myself just so that, it stays on you, but if you need me, I'll come right back on.
Okay. All right, let's go. Okay. All right. So again, thank you, Chef AJ, because this is truly an honor. I just want to welcome everybody from Orange County. That's where we're located here in Southern California. And it happens to be Sexual Health Awareness Month. And so we are celebrating this. The timing couldn't be any better to have this opportunity to talk about female sexual pain. I'm a pelvic floor physical therapist. I've done this for 20 years now. I've been practicing for 24, and you'll get to learn a little bit more about the pelvic floor if you haven't listened in before or if you missed Mandy's talk. We're going to talk about these muscles intimately and their role with sexual functioning. And I hope you walk away with a few golden nuggets today about sexual health and how you can improve this. So let's start by looking at some statistics. These statistics honestly are underreported and underrated, but this is what's out there in the literature. And this is shocking. Well, not in my world, because I deal with this every day, but I think people underestimate how prevalent sexual pain is. So we look and we see in general, about a third of women out there suffer with pain with sex. And again, we're talking about the women today. That's in general, 30% of women are suffering. About 5% of men suffer with pain with sex too. Now, when we start looking at somebody who is postpartum or even pregnant, 9 out of 10 women have pain the first time they have sex after they have a baby. Whoa, like that's huge. And again, no one's talking about this. We'll talk about why they're not talking about it, but this needs to be something that's brought up with the gynecologist. This needs to be something that we want to actually help prep these beautiful mamas' bodies for. So not only do we think about what happens just the first time after you have a baby and having sex, but when you look in the literature, they question women 3 months later after delivery, 45, almost 50% of people still had pain with sex. A year and a half later, you would think, oh, okay, well, maybe, just with time, it's going to disappear. Almost 25%, 1 in 4 still had pain with sex. So yeah, this is a big issue. Now, let's fast forward to a different time frame. So a time frame closer to the time frame I'm entering, because I'm a perimenopausal woman. So a lot of people associate menopause with, not only just a significant time change with your body, but that can be a time when you have pain with sex. So in general, between 20 and 30% of women who are postmenopausal, and I would include perimenopausal, also suffer pain with sex. Now let's jump to another classification. Women who suffer with cancer, not just breast cancer, it can be gynecological cancer, it can be colorectal, colon cancer. So specifically, the literature talks about 70% of women report sexual difficulties after breast cancer. So again, mind-blowing to me, because that's such a high number that needs to come down. And then another thing we want to think about, and we'll talk about as we go through our presentation today, but younger women who use the birth control pill, there is a certain percent population that will experience sexual dysfunction and sexual pain due to long-term use of the pill. And there was a study that looked at low-dose pill users, and they were twice as likely to report pain during or after orgasm than those that were not on the pill. So just to open up our minds. Okay, so we talk about sexual dysfunction, and today we're honing in specifically on the issue of pain with sex. And this is an older study back in the earlier 90s. So if we did this today, I think all these values would be increased, but it just looks at, on the bottom, you can see back through here, how many people, when they sampled this large population, had pain with sex. And here it was about 20%. It's really all over in the literature. I mean, some report up to 60% of women can have pain with sex, but other issues go along with this too, besides pain. So they look at, is sex not pleasurable? And in this particular cohort and study they looked at, almost 30% of people said, no, it's not pleasurable. How many were unable to achieve orgasm? Okay, almost 30%, that's a large amount of people. How many had just zero interest in sex? Okay, it's way on the end over here, above 35, almost 40% of in this sample, said, I don't really care about sex. How many people had anxiety about their performance? About 15%. How many people, and you can see the difference between women and men here. So how many had an issue with climaxing too early, having orgasm? So another issue with men actually being higher than 35%, but women still experience this as well. So just opening up the bigger picture here. Again, we're going to just hone in on, because this could be a whole weekend that we could talk about all of this. So we're going to talk about only pain with sex today. So first question I always want to ask is, pain with sex normal? Absolutely not. Never, ever, ever. So we got to bust this myth, because people are like, oh yeah, I guess that's just normal after I have a baby, or all these other times that we talked about, or, as I get older. No. So really it can happen anytime through the lifespan. We already talked about, it can happen with your first attempt. And people think that's quote normal. It can happen not just during or after pregnancy, but as long as you breastfeed, because there's hormonal changes that are happening and you don't have the same amount of localized estrogen vaginally. Any pelvic surgery that you undergo, you absolutely can end up with painful sex. And we'll talk about the role of the pelvic floor muscles and why this happens, and scar tissue. There are a lot of other pelvic pain disorders out there that exist. We're going to highlight today that pain with sex is part of that presentation, and there's so much treatment that's available to people who suffer with these issues. Again, we talked about cancer, whether breast cancer or the other type of gynecological cancers, birth control, and then even just extreme stress. And we'll talk about why the extreme stress can even influence sex and the pelvic floor muscles in particular. Okay, so what's going on? Why is painful sex really not being talked about and not being addressed? So we already mentioned it's taboo, but really when I dive into this, it comes down to not only is no one talking about it, but our healthcare providers are not asking. No one's asking. So there was a survey they did in 2016, and they surveyed MDs, primary care MDs, and they asked them, how many of you address sexuality in your history intake, in your medical interviews? 64% said they did not. Then the study went on to look at why. Well, why? So number one, they said, we don't have time. Number two, embarrassment. So they said embarrassment for the patient, but I would guess probably embarrassment for them too. And then inability to really address the issue. So if a woman comes to a physician and says, I have pain with sex, do they know what to do with that? Do they know how to evaluate it? So I think another, on top of the fact that no one's asking, if we do ask and we do talk about it, we unfortunately are a lot of times told the wrong thing, or women have been dismissed in the past. Totally not acceptable, and we're working on changing this. I pulled up this study, and this just blew me away. Let me go back, Chef EJ. I'm just gonna minimize this real quickly. So there, in 2012, there was a representative. Sorry, I'm gonna just change something right here. Her name was Lisa Brown. Okay, so she was in the caucus, and she used the word vagina. Okay, when she addressed like the caucus. The next day, they banned her from speaking on the House floor. This was in 2012. Okay, we're in 2020. This is 8 years ago. When I read this, my mouth just dropped open, and I was like, what the? I can't say it now, but I'm all, okay, maybe in the 1950s, but what? So we're not talking about it. And if we do, to be dismissed like that is so not acceptable. So I challenge everyone, use the words, talk about it with your healthcare providers, talk about it with your friends, talk about it with your family. I talk about it with my teenagers, let's just normalize it, and let's use the right terminology and wording. And today we're going to say vagina, and we're going to say clitoris, and we're going to talk about orgasm. So I hope you're all ready. Another issue why it's really not being addressed, I think, is shame. It's really hard. It's hard for somebody who suffers. And especially if they have been dismissed or told the wrong information. There's a thought for a lot of women that I am the only one, and this happens all the time when patients come into our clinic, is that they think, I am the only one suffering, and it is very intensely private. So a lot of people have a hard time talking about it, but they're so excited and I think just validated to learn that our clinic is full of all these other women who also have suffered with the same issues. And then the comment is, well, why didn't anyone ever tell me that there was help for this before? So again, thank you for giving the opportunity so we can get people the help they need. So let's continue and talk about and change the cultural narratives, and let's bust these myths that exist that pain, even though this is a common issue. We looked at the statistics. It is not normal. Okay, so we want to change what's happening through the media and the messages and marketing. And then I think lastly, we want to understand that why this is happening and the cause for this for every single woman really is individual. And it's not the same for every person, which I think is also a reason why it does influence or confuse practitioners too. And then our treatment is going to get dictated on what the underlying cause is. All right. Okay, there we go. So symptoms of painful sex. All right. Symptoms vary. And they can be anything, right? That really the patient, the wording that resonates with the patient. So here are some of the more common descriptors that we hear in our practice. Number one, sharp. I had a patient say, it feels like there are knives there all the time. On good days, it's like little paring knives sticking me. On bad days, they feel like they are butcher knives. Number two, a bruised feeling. And this is very indicative, both of these symptoms, that there is a pelvic floor muscular component that's feeding into your pain with sex. So whether sharp or more bruisey, achy, that's typically indicative of a muscular problem. Patients also can complain of rawness, like it feels like it's an open wound that is present, burning, stinging, and that could be mild or it can be severe, and it can feel like the tissue is on fire. Itching is another complaint we hear commonly, and it feels like patients have a constant yeast infection, yet they'll go get cultured and they don't have a yeast infection. Sometimes they get treated, unfortunately, still for the yeast or the UTI, despite culturing negative. But that tells us it's not coming from a medical issue. It's probably coming from a different issue, whether muscular, or we'll talk about some of the other reasons. Swelling, it can feel swollen dry, like sitting on a cactus. We want to figure out, is the pain superficial? Is the pain deep? Is it at the opening, or is it deeper within the canal? And if it's deeper within the canal, a common complaint we hear, it's like, he's hitting a wall, or my partner is hitting a wall. Skin changes, we always want to see, and the patient, we want you to look to see, is there changes in coloration? Is there evidence of inflammation, redness? Do you see scaling, fissures, which is just a small little cut, particularly down at the 6 o'clock area? We'll talk about this. If the tissue isn't as healthy down there, it can literally tear, and you can have a paper cut or microscopic tearing within the tissues. And then sometimes too, patients, even, it's not just limited to sex. It is, oh my gosh, I have pain when I wear really tight clothing or jeans, or the seam in my pants, or wearing underwear really bothers me and I can't do that. And oh yeah, and I notice when I sit for a long period of time, I get really uncomfortable, or I ride a bike, and this can exacerbate any of their vulvar pain or even deeper vaginal pain. Okay, so early signs that you can look for too, if you experienced pain with tampon insertion at the time you started your menstrual cycle, this is a red flag. This is not normal. So, you know, that is something. For example, I have a teenage daughter who's 14, and she started her period last year. And she has this problem. So being a pelvic floor PT, I am on this, right? So I'm working with her in terms of teaching her ways to lengthen and release her pelvic floor without me doing anything, because she's completely freaked out about me doing anything personally. But there's so much we're going to talk about with breathing and stretching and other things that you can do. But that is not normal if you have pain with tampon insertion. It is not normal if you have pain with a gynecological exam. All right, so very common. We already talked about wearing underwear. If you have also painful periods, this can be a sign. And what happens is that every time that menstrual cycle comes and your pain kicks up, the pelvic muscular component is going to respond. And we'll get into the anatomy in just a bit. And we talked about pain with sitting. All right, so what are some other questions that we can help identify? Because remember, we have to figure out what's the cause, underlying cause, because we don't know the treatment until we can figure out what the cause. So when a woman comes in to see us for painful sex, we're always going through, the history is so critical. And sometimes we got to go way back, and it's not just a recent event, but it can be something earlier in life. So we always ask every woman, what do you think is the cause? Can you relate this to any specific event that has happened in your past? Sometimes they can, sometimes they can't. And, you know, I think about all the different women. Sometimes it takes not just during that first visit to really identify, but sometimes they'll come back in second or third visit and they're like, oh, you know, I was thinking about it after I left. And like, for example, I had a patient who said, I think this all is traced back to when I was 8 years old and I had a significant fall. This was a story that happened. So this young woman came into me. She could not consummate her marriage. She had waited to have sex until she got married. So there she was, right on the night of her marriage, and she could not have sex because of severe, severe pain when her husband tried to have penile insertion. So she traced this back, and we found that she had had this fall back when she was 8 years old. She had been climbing on a tree, and she had a split injury like this, right on a tree branch like this. And she recalls that she couldn't pee for about 24 hours after that. Her mom had soaked her in the bathtub. But back then, her pelvic floor muscles probably went into spasm. And while she didn't walk around with pain day in and day out, right, she didn't realize that these pelvic floor muscles, which we'll talk about, and you'll see in just a few seconds here, a few minutes, were in this shortened hypertonic state. So Fast forward when she was a teenager, yeah, she couldn't use a tampon because that was painful. And then fast forward when she got married, or, you know, even if you're having sex without, you know, being married doesn't matter, whatever first sexual encounter is, she couldn't have sex that was pain-free. So we were able to put the pieces back together. Another question we always ask is, did you ever have sex without pain? Ever in your life? So, or did you have a time period where it was pain-free and then there was an event or a time period where the sexual intercourse or just sex in general, doesn't even have to be intercourse, became painful? So that gives us a ton of information. We want to know where is the pain? Is it at the vaginal opening? And is it in the vulva? We're going to talk about what the vulva is versus the vagina. And even in the vulva, where? We looked at the anatomy very specifically. And then how long has this been going on? Has this been going on for years or months? And why we want to know that is because it's going to give us a good indication on how long it's going to take to undo some of these issues. We want descriptors, like we already talked about. Is it sharp? Is it burny? You know, sharp muscle, burny more nerve. Burny could be suggestive of a hormonal issue. We want to know what makes it better. Does anything make it better? Does a position change make it better? Does a certain lubricant make it better? What makes it worse? And then we want to know what's going on with your history. Is there anything else in your history? What, you know, if you have had children, what is going on with your birth history? What's going on with in terms of sexual health history? Any history of abuse, any history of extended birth control use. So these are, we go dive in deeper, but just to give you an idea. So I always like to say that we get to be the detective on the case as pelvic floor PTs. And this is like my favorite part of my job because I love putting the pieces of the puzzle together. And it's very empowering too, because the patient really figures this out. So let's look now a little bit more at what are some causes specifically of pain with sex. So first thing, typically if a woman goes in and presents with painful sex as a complaint or an issue to her physician, the physician's going to want to rule out infection. Is there any infection? So classically, they're going to run labs, they're going to test, they're going to do cultures. We're going to make sure that there is no, whether a bacterial vaginal infection, a UTI, yeast, any kind of, or sexually transmitted disease, any type of infection. Most often, these all come back negative, right? But it's just kind of the go-to thing, and we need to rule that out. Next thing we talk about then as a cause, we have to see, well, were there any injuries or trauma? I give you the example of the patient, you know, with the tree trunk, or it could be, think of a bike injury, or even a motor vehicle injury, or a big fall or an accident. There's a lot of trauma that can happen with childbirth. We'll talk about, particularly with vaginal delivery. Trauma related or injury related to pelvic surgeries that happen. Then we're going to look at as a cause the muscular element. We're going to look at the pelvic floor muscles. I'll show you a nice, beautiful picture of all those and get you familiar with where they are, what they do. Another cause we look at then can be related to either what we call a sexual pain condition or a pelvic pain condition. And I'm going to highlight these four today. The common ones we treat in our practice are called Vulvodynia and Stibulodynia. Another sexual pain and a pelvic pain diagnosis that we work with routinely is called Interstitial Cystitis or painful bladder syndrome. Another one's Pedental Neuralgia, and another one is endometriosis. So for some, they're like, I have no idea what you're talking about. That's a big bunch of mumbo jumbo. But if you do suffer with one of these, usually painful sex is part of the presentation. So we'll highlight this, but know that each one of these diagnoses could be a whole different talk in and of itself, and could be like a whole conference around this. So we'll just touch on it on the superficial level because there are some commonalities that exist regardless of what the diagnosis is and with treatment. Okay, hormones, as hormones change, right? Tissue changes. estrogen is a vasodilator. So what that means is it brings blood flow into tissue. So during our life, when we undergo these changes in hormones, and that can happen during pregnancy, we don't get the same amount of estrogen vaginally during pregnancy as well as anytime we are breastfeeding. So we're going to have some vaginal tissue changes and vulvar tissue changes going on. Menopause is the other big one, where as we start to lose estrogen, right, there's going to be a change in our tissue, knowing that that vasodilation is not happening now locally in the vulvar region as much and vaginally. By the way, we don't only just lose estrogen, but we slowly also lose testosterone as we age. And then the birth control pill use also changes how much estrogen you have locally, as well as available testosterone to get into your vulvar tissues. And we'll talk about in just very shortly how that happens and what that does, the consequence of it. And again, not for everybody, just a certain percent of the population. All right, if you have pain with sex, you have to consider, are there any skin conditions that are present? There's something out there called lichen sclerosis. This requires a biopsy, and you have to look at tissue under the microscope to see if there are true changes within the tissue. We look at scar tissue, we look at inflammation, and then the effects of cancer, and it's usually the effects of the treatment of radiation, which causes a lot of fibrotic tissue. Okay, so now that we know some of these things that cause pain with sex, I want to dive into our anatomy a little bit more, because we as women, I think, and even men out there really don't understand anatomy when it comes to pelvic anatomy. So this was Hannah, this made me laugh. She's like, I don't even know what a vulva is. The word makes me think of vulvas in Volvos, and she's a mama of 3. And this is not limited, I think, also just to, to women. I mean, it's just across the board. Honestly, even our healthcare professionals don't really understand it. So they, as an example, they did a study in 2016. They looked at 1,000 different women in Britain, and they showed them a diagram, a medical illustration, and almost half of them could not ID the vagina within this illustration. And then even fewer were able to identify the vulva. So like 60% of them were like, I don't know, vulva, what the heck? So here is the vulva. Let's clear the muddy waters. And we're going to talk about what the difference is between the vulva and the vagina. So the vulva is a collective term that's used for all the anatomical structures that house the genitalia. There's a beautiful picture here, actually. This is drawn by, her name is Kendra Perfumo, and she has a beautiful Instagram following, and she does medical illustrations for art. So let's quickly go through the functions. What does the vulva do? Number one, it gives us lots of great sensory experiences during sex. It actually helps us with urination by directing the urine flow. And then it helps protect the deeper vaginal canal from infection. So if you're looking on the diagram, what you can see is all of this includes the vulva. So we have at the very top, if we go up, we have the clitoris, but what you see is that little teardrop shape. That's actually the glands of the clitoris. And a lot of people think that is all the clitoris is. And we're going to dive in and show you that the clitoris is much more than that. There's a hood of tissue that comes right over to protect that. You have 2 pelvic floor muscles superficially that come up and attach onto that hood and help control that hood. And then we have, if we go to the very outside, we have the labia majora. Those are our big lips, okay? And right inside, you can see the labia minora. And these are outlined on this diagram really nicely. They should come down and they should meet right down at 6 o'clock at the bottom towards where the perineum is. And that area down there is called the posterior fourchette. And the labia minora think of them as these beautiful little lips to help, again, create closure, to protect what's happening right inside. So if we open up the labia minora, we go to the next level, and it's called the vestibule. Do you see on the diagram, it says the vulvar vestibule. So the vestibule is, I always like to say, the entrance to the holy place, right? Or, and it is truly, the vestibule is not muscle. The vestibule is not the vagina. The vestibule is right outside the vaginal opening. So on the diagram, you can see the vagina sits right inside, and the vestibule surrounds the vaginal opening. It surrounds and houses the urethra. So that's the tube we pee out of. And right next to the urethra, we have these two little glands called the Skene's glands, and they actually secrete fluid. And women can actually have, quote, female ejaculation, and that's where that occurs from. The vestibule is also houses all these vestibular glands. There's a major one called the Bartholin's glands, and the job of these glands is to secrete a lot of good lubrication when we get aroused. All right, so that is your vulva. Now, let's look a little bit closer at the clitoris before we go into the vagina. There's a great book out there I love, and it's called Becoming Clitorate. It was written by Lori Mintz, and so I highly recommend it if you want to really learn more about this, because again, I think women don't understand. The picture you see on the right is truly the entire clitoral structure. So what most don't understand is again, it's not just that little nub, it's not just the glands, but it actually has a whole extra structure with two legs coming down and two bulbs. And it's got a shaft even coming that helps support it. So, the clitoris, when we talk about sex, and talk about what sex is, I think a lot of people miss what happens with this particular structure. And so just to quote Alfred Kingsley, so intercourse is not the best means of pleasure for women. The clitoris is the center for female pleasure. And it's really the only human organ whose sole function is truly just sexual pleasure. So this is a really important little structure. We want to get that whole picture, and you want to understand. So those two teardropped hot pink bulbs that look or that are right inside the legs right there, that is fully erectile tissue, and those sit right underneath your labia minora. So know that all of this can be stimulated to work too, to help with arousal and sexual pleasure. And this has potential area also to become painful. So you need somebody who knows how to assess what's happening with your clitoris. Okay, here's just one more picture of the clitoris before we leave it. So you can see what happens is that it actually is innervated by what's called the pudendal nerve. And there's one particular branch that comes right up through here. And the main nerve that innervates the whole pelvis is the pudendal. Comes off of the sacral region in our spine. So the clitoris, just like the vestibule, is highly dependent on hormones. And the hormones are both estrogen and testosterone. And the good news is, if you're like, man, I just don't feel anything there, if you suffer more with not just a pain dysfunction, but maybe an orgasmic dysfunction, where you're like, I just don't have sensation there, I'm not able to have an orgasm, or it's just really diminished, you can actually change and hypertrophy the glands of the clitoris by applying hormones there, estrogen and testosterone, if it has atrophied. And you have to work with a really good physician who understands this and knows how to prescribe. So it can change in size. So know that. So really the clitoris is also equivalent to the male penis, because it has a shaft and it's erectile tissue that we talked about. So know again, if there's pain or even dysfunction here, help is available. All right. So the vagina, what's the vagina then? So the vagina is this elastic hollow canal, and the walls are made of muscle or of nerves and blood vessels, and it connects to the uterus, or the outside world essentially, to the uterus. So that's what the vagina is. Okay, when we're not aroused, the two walls of it just lie flat. And then with arousal, it will truly change with its size and its shape, and it becomes lubricated. And in the front, it narrows. And then in the back, it actually gets wider and it elongates, and it goes from 3 to 4 inches to 5 to 6 inches. And we call that vaginal tenting. Okay, so the muscles, I've been talking about these pelvic floor muscles. At the very end, after I come out of the presentation, I'm going to show you a 3D model of this. But we all have these skeletal muscles that exist on the, quote, inside. Actually, we have some of them that are superficial, that are you can palpate and access externally too. But this refers to a collective group of skeletal muscle that runs from the pubic bone in the front, wraps around the vaginal opening, wraps around the rectal opening, and attaches to the base of the spine. It attaches to our coccyx as well as our sacrum. And then 2 of the associated muscles of this bowl of musculature leaves the pelvis, and they go out and attach on the hips. So these muscles, I love to call they're the forgotten muscles, because no one really talks about them until a problem happens with them. So if you didn't catch Mandy's talk, I'm going to just quickly review. So these muscles have 4 different purposes. Number 1, obviously, a sexual functioning purpose. The muscles need to be able to elongate, to be able to lengthen out so that we can have penetrative sex. They need to also be really strong and contract, because their strength will help contribute to orgasm. Number 2, they have a supportive role, and they hold all our organs up. Number 3, they actually have a stability role, so that every step we take, they're firing with our abs and they're firing with our low back muscles to create stability for the whole pelvic girdle. They're part of, quote, the core, the inner core. And then the last function is a sphincteric function. So they help really create closure around the sphincters, both the urethral sphincter and then the external anal sphincter, so that we stay continent. All right. So what happens when these muscles become dysfunctional? Well, a couple things happen. Today, we're going to hone in on what happens when the muscles become too hypertonic. So everyone has heard of, quote, a Kegel. And when they hear that I'm a pelvic PT, they're like, oh, I do my Kegels. I'm like, oh, that's awesome. That's really good. But oh my gosh, it's not all about the Kegel. How do you release after you contract that pelvic floor? And that actually, we treat a lot more patients that we are teaching them, quote, reverse Kegels, and we're trying to lengthen out the pelvic floor because it's not healthy. So, signs of a, quote, hypertonic, and hypertonic just means the muscles are too overly active at rest, right? They're short, and it's like making a fist. And I always use this analogy with patients, and I say, if I ask you to make a fist for 24 hours a day, 7 days a week, do that for 6 months, what's going to happen at the end of that 6 months? Are you going to be able to do this? And they're like, no, I'm not. You're right. And by the way, look at what's happening with my knuckles. They're white. There's no blood flow in there, right? And by the way, if you have a nerve running in through the muscle area, right, which we have the pedental nerve that runs through the pelvis, that helps feed into the clitoris and the perineum and the external anal sphincter. And if this is happening, is that nerve going to be happy? No, it's not. So, we really come back in and we have to say what's happening with the state of the pelvic floor muscles. So since today we're talking about sex, again, we're going to know that this is a huge contributor to pain with sex. Huge. It's missed all the time. My goal eventually is that every OB-GYN out there across the US would learn how to do a pelvic muscular exam when you go in for an annual exam. They need to stop and feel what's happening with these muscles, because if we can catch this early, we can absolutely help women resolve it early. We don't want the patient coming in to us 39 years later. I had a patient came in. Her complaint was, I have been married for 39 years and never consummated my marriage. Never. 39 years. So I had to have a poker face, because I remember thinking, I'm like, man, I don't know if I can help somebody after 39 years. I mean, that's a lot of significant muscular and tissue change that has gone on. So, but I said, okay, all right, let's see what's going on. Let's do your exam and let's see where we land. And lo and behold, we were able to get her to have sex. It was a long journey, and it consisted of really normalizing all these muscles right through here that you see on this picture. So it consisted of internal work. It consisted of external work, because you have 30 muscles that attach on the pelvis. It's not just what's happening on the inside. So what happens on the outside influences the inside. What happens with your posture, what happens with how you sit, stand, or breathe, all that influences the pelvic floor. So we worked on all of that, and I probably was able to help, quote, normalize her pelvic floor muscular component by about 70%. But I'm like, I don't know if I'm going to get this last 30%. I had her self-treating. She was treating with dilators and a wand, and I'm going to show you pictures of that. But I referred her over to one of my colleagues who's a physician, and I'm like, all right, I need some help. And so we were able to get her pelvic floor normalized, the muscular tone, actually by having the physician do Botox into her pelvic floor. So this took her home all the way. And then we normalized with hormones and other things too, so that the tissue was very healthy. It was a great story, because I always say now, after treating that case, I'm like, never say never. It's, you don't know. And healing is always possible. And this patient had been referred to me by a sex therapist in the community. And I saw that sex therapist a few months later after I had discharged the patient. And we were at a conference and we high-fived each other, because we're like, yay, together. Like, it was the team, the healing team that did it. We're so happy. And I said, have you ever seen her back in your office? And she said, yes, I have. And she and her husband came back in, because now I had to help them through the whole grieving process after they realized what they missed for all that time. So let's not have people wait. Let's get them in early. All right. How are we doing? Let me just look at time. Okay. So let's look at pain with sex due to childbirth, because this is a very common problem. We have, again, it's a pelvic floor muscle problem that happens. So the pelvic floor really, during this time, tends to get a bit overloaded, and it's not uncommon for it to become a little bit hypertonic, because we have relaxin flowing. So as the baby's growing, the pelvic girdle has to change and expand. We have all these changes in posture and center of gravity. And then when it comes time for delivery, there's always potential for a scar tissue, for a perineal tear, or sometimes an episiotomy is done, and then scar tissue can develop. And women need to understand that they can learn to work this tissue and normalize it again. All right, I'm going to move forward because I'm a little behind here. Childbirth, it is amazing when we look at what happens to the pelvic floor muscles as vaginal birth occurs. And there was a study done. So Dr. Delancey, he did a study and he worked with an engineer, and they went to the lab and they tried to figure out what actually has to happen with the pelvic floor muscles. And he used this quote bowling ball model. And when they looked at it, the engineer was like, man, that is just almost anatomically impossible that women can birth babies, because what needs to happen is that the first muscle, called your pubococcygeus muscle, it's our PC, it's the one everyone's like, oh, it's the Kegel muscle, has to stretch 3 times its distance. So it'd be like my arm stretching out 3 times its distance in order to have vaginal delivery occur without a problem. So pretty amazing. The body is so amazing. If we can actually get women in for some pelvic PT before to prep those muscles and help them lengthen out, guess what? Delivery can be so much better, right? So we don't have a consequence then of this perhaps, right? Of a tear. If the muscle doesn't stretch, if the tissues aren't going to elongate, what's going to happen? Then we're going to end up with a perineal tear. Okay. So tears can happen anywhere from grade 1 to grade 4. 3rd and 4th degree tears are the most severe. They go all the way to the external anal sphincter and even beyond. So our goal is that we want to prevent this from happening. We want to teach women how to work with their tissues, right? Because this can set the stage then for painful sex later, and this can set the stage for other issues as well. Okay, just a quick reminder for myself, because I wanted to talk about, again, go advocate for yourself if you are a woman and you, whether pregnant or not. But it is interesting in other countries, women, for example, in France, they get 12 visits of pelvic floor PT, pre and postpartum, just automatically, just because you're pregnant. There does not need to be a problem. So we need to shift our mindset here, and we need to get people help, and we need to look at prevention. Okay. We doing okay? A lot of information. We're going to jump into now another sexual pain disorder that we commonly treat that's out there, and it's called vaginismus. So what this is, it's an involuntary spasming of the pelvic floor muscles, the muscles that we talked about. So it can be influenced by anxiety and stress. And one thing to remember is that the pelvic floor muscular component is actually governed by our autonomic nervous system. So when we go into fight or flight, which is a sympathetic nervous system overdrive state, these muscles will just turn on, and nothing physically needs to change except for what's happening up here and the perception of threat or stress. And they've done studies to show with needle EMG that the muscles will just fire. Women laying down on a table, and they did needle EMG to measure how much electrical output's happening in those muscles. And all they did was show them scary scenes of a movie, and their pelvic floor electrical output just shot up. So looking at the mind body is so critical as part of treatment when you are suffering with pelvic pain, whether vaginismus or another cause, because we want to get that nervous system calmed down. We want to get women into the parasympathetic state, so the pelvic floor automatically will lengthen back out. Okay. So we'll go into treatment a little bit later. I'm going to just highlight a couple more of these common sexual pain disorders that we see in our clinic and that exist out there. So another common diagnosis is called Vulvodynia that results in pain with sex. So this is a term used to describe pain or discomfort of the vulva. Remember what the vulva is now, right? So it's more of that external structure that houses all the genitalia. So we hear different descriptors, again, burning, stinging, raw, irritated. And again, this is diagnosed after infection has been ruled out or a skin condition has been ruled out. So now that we know the anatomy, this disorder, I have to highlight this because I think we need to change our thinking with this. So dynia just means pain. So what this word means is, and dynia is from a Greek word that means sorrow and anguish. So when we say vulvodynia, we're talking about pain of the vulva, all right? What that does is it tells us, okay, good, we have pain there. So that's better to know than, quote, deeper vaginal pain, but it doesn't tell us anything more. So it's really not a, quote, diagnosis, even though that's what women get diagnosed with. It's more of a descriptor. It's very similar to us saying, oh, well, you have knee pain. Well, why do you have knee pain? Do you have a meniscal problem? Did you tear your ACL? Do you have arthritis? What's going on? So it's the same thing with vulvodynia. We have to go deeper and we have to say, well, what's the root cause? What is the phenotype? And what is setting the stage for this burning or this irritation of the vulva? Okay, so I try and break it down. I keep it very simple when I work with patients. I'm like, look, at the end of the day, it's got to be one of these things, right? Is it either a skin issue? Is it an inflammatory issue? Is it a muscle issue? Because we have muscles, right, that sit superficially right outside the vestibule and deeper inside? Is it a nerve issue? The main nerve that innervates the pelvis goes right to the perineum and goes to the clitoris, and that's the pudendal nerve. Is it an oxalate issue, which is byproduct of different foods that we ingest, and these can be excreted? They have little jagged edges, and sometimes they get embedded within the vulvar tissues, and they can irritate it. Or is it a combination? Maybe it's all of the above, or 3 of the above, or 2 of the above. We have to figure that out, because the treatment then is based on what the underlying cause is. All right, so the Stibulodynia is another diagnosis, but it's been considered in the past like a subcomponent of Vulvodynia. So this now gets more specific, and we go, oh, okay, well, you have pain of the vestibule. Remember, vestibule, entrance into the holy place before you go in. Very, very common sexual pain disorder that we treat in our clinic, in our practice. So, so this can be pain anywhere. We think of like a clock that exists in the vestibular region, either up high, right, at 12 o'clock up towards the clitoris and above the urethral opening, or low at 12 towards the perineum. Okay. And if a woman has pain here, right, with touch, penetration, then the muscular component in front of it and behind it is absolutely going to guard and protect. Now, the muscular component feeds into this pain syndrome too. What's important to understand about this diagnosis is that you have to treat both. So the vestibule is not muscle. The vestibule actually is made up of tissue embryologically that is the same tissue as your urethra, which is the tube we pee out of. So there's a great doctor we work with, Erwin Goldstein, and he calls the vestibule open urethra, because it's really all the same. And it does tell us why some of our patients who have another diagnosis called interstitial cystitis, or irritation with their urethra, or burning with urination, also have burning of their vestibule too. So this vestibule is very dependent on both estrogen and testosterone. When a young woman goes on the birth control pill, depending on how she methylates and is genetically primed, some women will end up with changes of their vestibule due to long-term use of the pill, because the pill will do a couple things. It will, number one, take away the local estrogen in this vestibular region. So now their tissues start to look, quote, more menopausal. Number two, it causes something called the sex hormone binding globulin to rise up. And as that rises up, it binds to your free floating testosterone in your body. And the testosterone cannot get into this vestibular tissue, which is so needed. This tissue needs both estrogen and testosterone to be healthy. So we get a lot of women in their 20s that come in that have pain with sex, and we link it back to what's happening with, oh my gosh, you've been on birth control. Maybe you started at 13 because of acne or whatever, for true birth control, or whatever the reason. So the first thing is we have to get the hormones normalized. We have to work with physicians that really understand sexual medicine. We have to look at, what hormone levels are. And then we treat what's happening with the muscle component, the fascial component, and the nerve component all around it. Okay. So I just summarized this, that really, again, we got to figure out the cause: muscular, hormonal, inflammation, birth control. And the last one I didn't talk about is something called neuroproliferation. Unfortunately, when you have inflammatory markers that can show up in this region of the vulva, in the vestibule, you can get something called nerve sprouting that starts to happen. So maybe instead of like 3 or 5 nerve endings coming in through that region, you all of a sudden have 10, because you had this nerve sprouting. So this very mild little light touch becomes interpreted as, it's that sharp, it's that burning, it's that cutting pain. And it's magnified through the nervous system onto the cortex. All right. Okay. We're getting there. We're getting there. This is kind of meaty. Sorry, I think I planned too much for this talk. Another sexual pain disorder that's very common out there is called interstitial cystitis, and it happens to be IC Awareness Month this month. It's also called painful bladder syndrome. Don't have time to go deep into this, but I am going to talk about just what this is. So that you're aware that a lot of patients who, and if you happen to have this, that there is help out there, and pain with sex does not have to be your normal with this. So really what this is, it's a pain syndrome that's commonly related to bladder filling. And then you get other symptoms like increased urinary urgency and frequency. And there's no UTI present, urinary tract infection present, or other pathology. It takes patients a long time to get diagnosed with this, on average up to 7 years, and they get misdiagnosed with chronic recurrent UTIs commonly. And the diagnosis is a little bit complicated because it's not always bladder based. And a lot of people think, and they go to the bladder, but what we see in our practice is the bladder is really the victim, and other drivers such as the muscular component we talked about, the pelvic floor muscles are actually part of or driving most of these symptoms. Or the pedental nerve is misfiring, which goes to the bladder, goes to the sensory branch, goes to the urethra, also goes to all these muscles, right? Or maybe there's detox issues or methylation issues or inflammation going on. So just to highlight that as another sexual pain disorder. Okay, 2 more and then we're done, and we'll talk about treatment. Endometriosis. This one is near and dear to my heart because I myself have suffered with endo and had a very long journey with painful periods. So much before I entered my pelvic floor journey, where I would, if I didn't take 800 ibuprofen, I'd be throwing up if I couldn't get meds popped into my system. And endo is something that, unfortunately, right now, on average, with the research, it tells us it takes 11 years for women to become diagnosed with this. So again, very grateful to have a platform just to start spreading some awareness about some of these issues that women suffer with. True etiology is really not well understood. We do know what happens, though, is that the it's endometrial-like tissue. It's not the true endometrial tissue, but it's like it. Shows up outside of the uterus, and it implants anywhere. And it can create this severe pelvic pain. It can create pain with your period, but it can create pain throughout the month as well. It certainly can create sexual pain. Some of the more recent evidence shows that they've been able to identify this tissue, endometrial-like tissue, in embryos, suggesting a genetic link too. And this, you absolutely have to find a specialist who really does understand this. Not every your general gynecologist is going to understand what endo is, how to treat it, and get you linked up with a good pelvic floor PT. Some of the symptoms: pain with your period, pain with ovulation, pain with sex, infertility, constipation, diarrhea, bloating. We call it the endo belly, and you're like, oh my gosh, I look pregnant. Back pain, groin pain, pain with pooping, and then urinary frequency, urgency too. So you can see there's a trend here where there's a lot of overlapping symptoms too with some of these different pelvic pain and sexual pain diagnoses. Okay, last diagnosis, and then we're going to dive into what to do for treatment, regardless of what you have going on. Pedental neuralgia. This is a biggie. This is a one that we treat, and we have patients that fly in actually from all over to see us for this. This is a hard diagnosis, but there is help for patients who suffer with this. So this is it's a neuropathic condition that involves the distribution of the pedental nerve. And as you look in the little picture, you can see the yellow nerve endings showing you where this nerve goes. We have 3 terminal branches of this nerve. This is the main nerve that innervates the pelvis. So one of the terminal branches goes up to the clitoris, one goes to the perineum, so that space right in between the vaginal rectal opening, and one goes back rectally and it goes to the external anal sphincter. Okay, it's a clinical diagnosis. You can't do an MRI. You can't do any kind of lab testing. You need to have a physician and a physical therapist who are very experienced with that to diagnose it. All the descriptors of pain vary, which confuses a lot of practitioners out there. Again, this is a beyond this presentation of what you do about it, but just know that there's help. A lot of people, the classic presentation is that they have pain with sitting, but it's not just limited to this. Some of our PN patients absolutely have pain with sex, but not all. And usually this diagnosis is caused, I would venture to say, in about 80 to 90% of the time, it's caused by a pelvic floor muscular issue. So now that you're going to go to your OB-GYN and ask for an eval of your pelvic floor muscles, you're going to be able to prevent this from ever happening, because you'll get in and get help if they're problematic. Okay. Oh yeah, I forgot about this. Okay. Before we go to treatment, breast cancer, sexuality. We already talked about 70% of women who are treated for breast cancer end up with sexual difficulties. Okay. Really, and this was a good quote I loved, anything that affects the female sexual organs will have repercussions on body image and on a woman's sexual life. So yes, we want to celebrate, right, what's happening in terms of all the advances and women living through breast cancer. But I want to challenge us to go even beyond that, and let's take care of these women after, and let's get their quality of life improved. And this is a big one that we really want to work with. We want to restore their tissue, the loss of tissue integrity that's probably happened with treatment, with chemo and radiation. We want to teach them how to treat. We want to get pelvic floor PT going. We want to get tissue integrity healthy. All right. Okay. I'm going to speed up because it's 3, Chef AJ. I'm going long here. Okay, menopause. Okay, we talked about a drop in estrogen. We talked about a drop in testosterone. Why does this matter? Remember, estrogen's a vasodilator, brings blood flow, and at the end of the day, it's always about blood flow. We know pH can get altered vaginally. We want to think about with menopause, again, I think everyone should go see a pelvic floor PT, get a pelvic floor muscular exam to see what's happening. We look at the vulva, we look at evidence of changes. We look closely then with physicians for those who are comfortable and want to look at HRT, hormone replacement. And those that don't, there are other things that you can do, like vaginal moisturizers, we'll talk about in just a minute. I think honestly, every woman over the age of 40 should be using a vibrator, because you can get beautiful blood flow into the pelvic floor. And yeah. Okay, so treatment now, regardless of what's going on, treatment is multimodal. All right, pelvic PT is going to be part of it, but there is a whole team that we are a part of. Okay, the exact treatment depends on what the underlying cause is. Get your detective hat on, right? There is not a cookie cutter approach to this. There are generalities that exist, though. We want to calm the nervous system down. Remember, if the nervous system's like, oh, I'm freaking out, I'm all upregulated, pelvic floor is going to react just to what happens up through here. Then we can treat locally, attack the muscular element, not just internal, but also external, right? We're going to teach stretches and exercises, and we're going to teach women how to use dilators and wands, and there's suppositories out there, and you can use moisturizers and the right lubricants, and even sit on cushions if pain is present when you sit. And then there's a whole medical treatment side where we look at certain medications and hormones and muscle relaxants and even injections if it's needed. So don't let this picture scare you too much. Don't worry, I was actually on the outside here, even though I'm under the towel. But we look at what's happening with all the tissues as a pelvic floor PT around both the vaginal and the rectal openings. So our role is to educate you, empower you. I always say, I want to pass the baton to you as the woman, right? So that you become your own PT. You know, we help. We talked about the nervous system calming, so we really guide, like, let's get you into whether it's going to be guided imagery or meditation. Deep breathing is so critical for so many reasons. Get into that parasympathetic state, get the diaphragm to drop, pelvic floor drops, right? We work and we teach patients We do it ourselves. We teach them. How are we going to work all the tissues externally around the pelvis, really up and down the spine, almost head to toe? How are we going to work on what's happening inside the pelvis? We do things like a laser, nerve glides, and then we got to strengthen the core. So I'll run through these really quickly just so you can see some pictures of me treating here. So these are just examples so people don't get completely freaked out. They're like, what are you going to do? So a lot of external work with different techniques using our hands, myofascial release, we call it, trigger point releasing, and connective tissue mobilization. Here I'm working on the picture on the end, right around the ischial tuberosity. This patient had pain with sitting. She also had sexual pain. We had to clear the tissue. I'm doing a gentle nerve glide of the pedental nerve there, right through there. We do with treatment glove up. We have to get inside. This is a picture showing internal treatment of what the pelvic floor musculature looks like. On the outside, we can prep the body with, this is our class 4 laser that we use here, and it decreases pain and inflammation, brings beautiful blood flow deep, much deeper than a traditional ultrasound. We teach patients, again, how to use certain tools as part of their home program. These are pictures of dilators on the right. There are a couple companies, great companies we work with out there. So one is called Intimate Rose. The other one is Soul Source. And women can gently work to gradually stretch their pelvic floor musculature to prep for intercourse. And then there are wands that can be used that are curved to actually get in and mimic a little more what we do with our hands when we work internally to release the restrictions and the bands and the quote trigger points within the muscles. A key component to understand is we're not just using our hands. We need to, after we lengthen, we need to strengthen. So we teach certain exercises, like you can see the woman on the far left is doing a squat. This is a beautiful release for the pelvic floor to lengthen it out that can be done. So I once had a patient and we were working, she came to us with painful sex and she was doing great. And we're like, okay, go do homework. You got to go have sex and come back and tell us what happened. So she came back, she's like, all right, it went so good. But then like, I don't know, about 5 to 6 minutes in, there was a sharp pain on the left when he was thrusting. So I'm like, oh, hold on. She's like, so I made him pull out and I dropped into a squat stretch and I did my couple deep breaths and then we moved back in and the rest was awesome. It was so great, Julie. I'm like, good. That's so awesome. She's like, tell all your women to squat. I'm like, all right. So, squatting, then we look at, so that's a lengthening move, but then we teach strengthening, core progressive strengthening, because if your other muscles aren't doing their job, guess what the pelvic floor is going to do? It's going to compensate. It's going to pull in. It's going to try and create stability through spasm. Okay. If dryness is an issue, right? If you're like my age, perimenopausal or menopausal, there are vaginal moisturizers out there that can be used. So this can help just maintain moisture throughout the week. Okay, you could get an effect about 3 to 4 days, reduces friction during sex, improves just overall, decreasing irritation and burning. There's different types, creams, gels, suppositories, oils. There are also, that's a different thing than a lubricant. Then there's lubricants that can be used short-term during sex. And there are 3 types. There's water-based, oil-based, silicone-based. 2, be careful if you're using a lubricant. Watch out for those containing glycerin or propylene glycol. KY gel is one of them. Glycerin can exacerbate vaginal yeast if it's already present, and propylene glycol can burn. So please start reading labels, avoid chemicals, try and go as natural as possible. HRT, we don't have time to get into. So I kind of highlighted already what estrogen does, but that is a whole different talk. So we're wrapping up now, home stretch here. And I want to just end with, please know, pain with sex is not normal. Pain with sex can be treated. Healing needs to occur, honestly, mind, body, spirit, because that's when the lasting permanent changes happen and it can be life-changing for you. So know that you don't need to suffer alone in silence. Know that there's help. We happen to be here in Orange County. If you're in Southern California, Sarton Physical Therapy, we're known on Instagram as Pelvic Healing. Please follow us. We try and put up really good content to help educate women across the world. On Facebook, if you're a Facebook person, Sarton Physical Therapy. Clinic phone number is right here. 714-770-8222. We are at pelvichealing.com. If you are somewhere else in the US, there are pelvic floor PTs out there. You can find them. The American Physical Therapy Association has a great way to locate them. The International Pelvic Pain Society has a great way to locate them. There's a whole database through Pelvic Guru. So there's a lot of different ways. You could simply Google pelvic floor PT near me and see what you find. Okay, and that is a wrap. And I am going to come back.
Wow, I feel like I was in a medical school course. That was amazing. Listen, I know you have to go.
Technical. I'm sorry.
No, it was great. And I know you have to pick up your daughter, but maybe you could come back and maybe even with Mandy and just do a Q&A and I'll save all these questions.
Yeah, you know what? Let's go for a couple minutes because I already warned her. Since I tend to
gosh, I don't know who to pick.
Good. So we could go. Yeah, we could go for 5 to 10 minutes, and then I.
Okay. The thing is I actually have an appointment.
Oh, you got
I when you said that you had to leave at 3:10, I made a 3:30 appointment, and so I'm so sorry. I can't do it. And then also, it's just too much pressure to try to pick which of these questions. So maybe you guys can come back either together or separate, and I will save this feed. I'll take a picture of it before I close it out.
Okay. Sounds good.
That was amazing though. And we had mostly women watching. The guys, I think, were a little dumbfounded and they kind of left, but these are actually the people who should see this. So this is amazing. And guys, I'm going to have to watch this again. This was really, really helpful. So thank you so much, Julie.
You're so welcome. My pleasure.
Absolutely. I wish there was somebody like you in our area, but actually there are some. You just have to find them.
You just got to find us.
Wow. Yeah, you have to. A lot of times, your gynecologist will know, or your urologist will know, or even a physical therapist will know. So It's getting a lot more popular.
Correct. Absolutely. Yes.
All right. Well, thank you guys so much for watching. Please come back tomorrow at 11 a.m. when Chef Anthony Cruz, a local chef from Indio, is going to be making some amazing recipes. Thanks again, Julie. Take care.
You're welcome. Bye.
Okay, bye.